Simple tests could save your life. For many men, that's the reality of prostate cancer screening. Early detection can mean the difference between a treatable condition and a life-altering diagnosis. Consider former U.S. President Joe Biden, who in May 2025 was diagnosed with advanced prostate cancer at age 82. His cancer had reached a very late stage, with a Gleason score of 9 and spread to his bones. A devastating outcome that might have been avoided with earlier screening. While screening isn't recommended for every man, especially those over 70, Biden's case is a powerful reminder of why understanding your options matters. This guide will break down the key screening methods for prostate cancer and explain how they work, their benefits, and their limits, all in simple terms to help you take charge of your health and avoid a similar fate. Prostate cancer is one of the most common cancers among men, affecting nearly 1 in 9 over their lifetime. When caught early, the survival rate exceeds 90% for localized cases. But when it's found late, as in Biden's situation, the cancer can become aggressive and spread, making treatment much harder. His Gleason score of 9, a measure of cancer aggressiveness, and bone metastasis highlight the stakes of delayed detection. While most prostate cancers grow slowly, Biden's experience shows why being proactive can be critical, especially if you have risk factors like family history or are of African descent. Screening tests aim to spot prostate cancer before symptoms show up. The two main methods are the prostate-specific antigen (PSA) test and the digital rectal exam (DRE), with additional tools like MRI and PCA3 used in certain cases. Here's what you need to know about each. Number 1. Prostate-specific antigen (PS) test. The PSA test is a blood test that measures the level of prostate-specific antigen, a protein produced by both normal and cancerous prostate cells. It is the most common initial screening tool for prostate cancer. Normal PSA levels are generally below 4 nanograms per milliliter, but this threshold can vary based on age, race, and other factors. Levels between 4 and 10 nanograms per milliliter may indicate a 25% chance of cancer, though many are low-grade. Levels above 10 nanograms per milliliter suggest an over 50% chance of cancer, though some may still be low-grade. The pros of PSA testing include its non-invasiveness and wide availability, making it suitable for routine screening. It can detect early signs of prostate cancer, potentially improving outcomes if the cancer is aggressive, and paving the way for timely treatment. The main limitation is that it is not specific to cancer. Elevated PSA can result from benign conditions such as benign prostatic hyperplasia, BPH, or prostatitis, which can lead to false positives. Whether to proceed depends on factors such as age, family history, and previous PSA trends. It is also important to note that some aggressive cancers do not raise PSA significantly, which can result in false negatives and potentially missed cases. PSA test is commonly used as a first-line screening tool for men at average risk, typically starting discussions around age 50, or earlier like age 45, for those with higher risk, such as Black men or those with a family history of prostate cancer. PSA levels can be influenced by recent medical procedures, such as prostate biopsy, medications, or infections. These factors must therefore be considered when interpreting results. While the PSA test is a great first step, an abnormal result does not confirm cancer. It may prompt further testing, such as a biopsy. Talk to your doctor about what your results mean for you. Number 2. Digital rectal exam. A digital rectal exam, DRE, is a quick, non-invasive physical examination in which a healthcare provider inserts a gloved, lubricated finger into the rectum to assess the prostate gland. During the exam, the provider checks for abnormalities such as lumps, hard areas, or changes in size, shape, or texture. The exam also allows for evaluation of the lower rectum and anal sphincter function. DRE requires no special equipment and can be performed during a routine physical exam. It may detect issues that the PSA test misses, providing valuable additional information. An abnormal DRE may prompt further testing, such as MRI or prostate biopsy. It is often used alongside other diagnostic tools to provide a more comprehensive assessment of prostate health. However, DRE has limitations. Its sensitivity is relatively low, especially for early-stage cancers located deeper in the prostate that may not be detectable by touch. Benign conditions like benign prostatic hyperplasia, BPH, can also feel abnormal, potentially leading to false positives. Therefore, its value as a routine tool is debated among experts, particularly as more advanced imaging techniques like MRI become increasingly accessible. Despite the controversy, DRE is still commonly used, especially in patients with urinary or sexual symptoms, or those at higher risk for prostate cancer. When combined with PSA testing, it can offer useful clinical insights and support early detection in select cases. For patients with abnormal PSA or DRE results, or those with persistent suspicion despite negative initial tests, additional methods can refine risk assessment and guide further steps. One such method is multiparametric MRI, MPMRI. MPMRI is a specialized type of magnetic resonance imaging. It provides detailed images of the prostate using multiple parameters, such as T2-weighted imaging, diffusion-weighted imaging, and dynamic contrast enhancement. The MRI scan creates high-resolution images to identify suspicious areas that may indicate cancer. These are reported using the Prostate Imaging Reporting and Data System, PIRADS, where 1 means very low likelihood of significant cancer, and 5 means very high likelihood. MPMRI is highly accurate for detecting clinically significant prostate cancer, reducing the risk of missing aggressive cases. It can also help to guide biopsy procedures by targeting specific suspicious areas, thereby improving diagnostic accuracy. One disadvantage of MPMRI is that it is pretty expensive and not always covered by insurance for screening purposes, which limits accessibility. Typically, MPMRI is used when PSA levels are elevated but a biopsy has been negative, or when there is persistent suspicion of cancer. Usually, it is often reserved for higher-risk cases rather than being used as a first-line screening test for all men due to cost and availability. Recent advancements, as discussed in a 2025 article from Johns Hopkins Medicine, emphasize MPMRI's growing role in personalized screening strategies, particularly for men with prior negative biopsies. Another screening method helping to detect prostate cancer is the PCA3 test. PCA3 test is a urine test that measures PCA3, a gene overexpressed in prostate cancer cells. It is more specific than PSA and helps decide if a biopsy is needed, especially after a prior negative result. A higher PCA3 count suggests a greater likelihood of cancer. PCA3 test is more specific than PSA, as it's unaffected by prostate size or benign conditions, reducing false positives. As it is less widely available, it can be used alongside PSA and other methods. Similarly to MPMRI, PCA3 helps to determine if a repeat biopsy is needed in men with elevated PSA but a negative biopsy, or in cases of persistent suspicion despite normal PSA levels. In addition to MPMRI and PCA3, tests such as the Prostate Health Index, PHI, or 4K score use extra blood markers to improve risk estimates and reduce unnecessary procedures. Talk to your doctor about all these options, and about if a prostate biopsy is needed afterwards. Prostate biopsy is the most important diagnostic step. When screening hints at trouble, a prostate biopsy is the most reliable way to confirm cancer. It's a procedure that takes small tissue samples from the prostate for microscopic analysis. Usually guided by ultrasound or MRI, doctors use a needle to collect samples from targeted areas. Results show if cancer is present and how serious it might be. Using the tissue from the biopsy, doctors determine the Gleason score by looking at cancer cells under a microscope and comparing them to healthy prostate cells. The score runs from 6 to 10. A higher score means the cancer is more aggressive. A score like Biden's 9 signals highly aggressive cancer with a greater chance of spreading. Prostate biopsy delivers a clear yes or no on cancer, guiding treatment decisions. A biopsy is the gold standard for diagnosis, but is typically done only when screening or symptoms justify it. Discuss the pros and cons with your doctor. Screening isn't for everyone. It depends on your age, health, and risk profile. Here's how to approach it. Prime screening age. Men 55 to 69 often benefit most, especially with risk factors like family history. Over 70? Think twice. For older men like Biden, routine screening may not be advised unless symptoms appear, as slow-growing cancers might not need treatment, and risks of overdiagnosis rise. Partner with your doctor. Your screening plan should be tailored to your unique situation, taking into account factors such as your health, heritage, and preferences. Prostate cancer screening isn't perfect, but it can be a game changer when used right. Tools like the PSA test, DRE, and advanced options like MRI give you a shot at catching cancer early, when it's most beatable. Joe Biden's late-stage diagnosis is a sobering reminder of why awareness matters. Don't wait for warning signs. Talk to your doctor today about the best approach for you. If you have any questions or comments, please don't hesitate to leave them below. If you found this video helpful, we'd appreciate it if you could like and subscribe. Thank you for watching.